So Seattle and CROI this year was exciting and was a more interesting conference than you might have suspected. So the first two discussions are about PrEP trials. We heard about these two trials prior to CROI in press releases because both of them were ended due to the Data Safety Monitoring Board early. So they're both interesting and I think quite important trials. The first one is called PROUD. It's a UK study. And this was essentially called a real-world trial in that it was not placebo-controlled, but individuals were either randomized to Truvada versus, sorry, not randomized to Truvada, but immediately started Truvada versus a delayed start. The primary endpoint here was HIV seroconversion within the first 12 months. And as I mentioned, in October 2014, the DSMB ended this trial early, and then this was the first time the data was presented formally. Along the bottom here, you can see this was a very high-risk patient group. Average age, 35 years, 81% white, 54% not in a current relationship, and 70% using recreational drugs in the last 90 days. The entry criteria was higher risk sex, engaging in condomless anal intercourse, and they tracked behavioral modification through this study. So some of the criticisms, of course, of PrEP trials is that there may be a disinhibition or a behavior compensation, and people are always concerned as to whether or not individuals are going to take higher risks and we're going to see more sexually transmitted infections or more problems, and that may, of course, negate any benefit of PrEP itself. So this study was deemed to be real world in that there wasn't a placebo control, so all of the participants knew that they were on therapy right up front, open label. So the results, there were 19 cases of infection in the deferred treatment versus 3 in the on-treatment group for an 88% reduction, or pardon me, 86% reduction in transmission. So first of all, 2 points, a surprising high incidence of 8.9. Typically in these studies, a range of 4 to 6 is usually expected. So this is a high rate of infection in the deferred group, I think reflecting the higher risk patient group that I highlighted in the first slide. But a tremendous and perhaps more than expected reduction in incidence. This translated for a number needed to treat for numbers of individuals needed to treat for 1 year of 13 to prevent 1 HIV infection. So I'd like you to bear that in mind because it's quite important. And then the other, and I'll come back to it when I present the other study. And the other important thing is there was post-exposure prophylaxis used in the deferred arm, so that is even more impressive when we see this risk reduction. So tremendously more than most of us expected. We certainly thought it would work, but 86% reduction is spectacular. As I indicated earlier, the criticisms of PrEP, I think, from some corners are that there may be a behavioral change if people believe they're on PrEP, and we may see more other STIs or hepatitis C, etc. And this was tracked very well in this study. I should comment that that hasn't been seen in any of the previous PrEP studies, and in this case it wasn't either. So if we look at baseline versus month 12 in either the immediate or deferred arm, you can see that the total number of partners and then what type of sex are involved do not significantly change over that time. So behaviors over the 12 months do not change. And in fact, there wasn't a disinhibition as some people would predict. Looking at sexually transmitted infections, you can see that numerically there's a little bit higher for some of them in the deferred arm, in the immediate treated arm versus the deferred arm, but p-values show that there's no statistical difference. So no behavioral change and no increase in STIs as some people would have predicted. The second PrEP study, something called IPERGAY, which was conducted both in France and in Quebec, and some of our colleagues in Montreal participated in this. And this was a similar study of high-risk MSMs, defined in this fashion with some safety data combined. You'll see that the population was also similar in that there was a fair amount of use of recreational or psychoactive drugs, and again, similar number of partners, and a very similar makeup to the previous trial. In this study, the design was somewhat different in that PrEP was used on demand, so to speak, or per event. So individuals would take tenofovir 2 to 24 hours before sex or the day of, and then an additional tablet the next 2 days, so a total of 4 tablets per event. So the logic and the thinking with this study was to see if this would make PrEP be more appealing from the point of view of side effects, cost, and frequency of use, and whether or not individuals who deemed themselves to be at higher risk at certain times could use it in this fashion to help reduce infections. So a novel idea and certainly some significant interest. So the results here also very similar. In the placebo-controlled arm, there was 6.6. You'll remember from the previous, it was 8.9. The reduction is identical at 86% down to 0.94, or 14 cases of infection in the placebo arm versus 2 in the PrEP. I should point out that the 2 who became infected in PrEP had no levels of tenofovir, and there may have been an issue from the point of view of adherence. Safety was deemed to be very good and overall quite acceptable from patient use. So it's dramatic that and remarkable that both of them showed such a significant decrease in similar results. I don't have listed here, you'll remember that I indicated that the numbers needed to treat was 1 in 13. In this study, it was between 1 in 15 or 1 in 18. I wanted to just say a few words about this, about the number needed to treat and the benefit of PrEP from that point of view. We could extend that argument into cost effectiveness and other arguments. I won't get into that. This is a slide I took from Paul Ridker, one of his papers. He is the very famous cardiologist, as you know, from Harvard, who did the Jupiter study. And this is basically a 5-year number needed to treat values for to prevent one major cardiovascular event, looking at statin treatments, diuretics, beta blockers, and then aspirin. Now the comparison here is a little bit apples and oranges, because in the other study it was numbers needed to treat over 1 year, and this is 5 years. But that even favors the PrEP studies. So interventions that we deem very cost effective and standard of care, such as beta blockers and diuretics to prevent heart attack or stroke. In the case of beta blockers, it's between 130 and 140 numbers needed to treat over 5 years, versus diuretics somewhere around 80, and with statins we vary between 25 and 40. So this number of 1 in 13 to 1 in 18 is really quite substantive. These are 5-year treatments versus the 1-year treatment. So the argument being, we're not handing out a lot of Truvada at great cost and exposing people to a lot of side effects necessarily with those terrific numbers. Continuing with prevention, this was an interesting study looking at from Africa. This is heterosexual couples this time, discordant African couples. There's several cohorts in Africa, but what this looked at was the rate of transmission over 6 months in a discordant couple following the infected patient being treated. And basically the bottom line is they looked at the rate of infection in the negative individual prior to antiretroviral therapy within the first 6 months and then following 6 months. So not surprisingly, but rather glaringly obvious here, the rate of infection and seroconversion in the negative partner was almost equal in the first 6 months. So as we would predict, not having the infected patient, the infected partner fully suppressed, there still is significant transmission, and past 6 months, we're protecting that partner. So this has led to something called the Partners Prep African Demonstration Project, where this was applied in a more larger policy manner. And basically, individuals, if they chose to or for other reasons delayed HARP, initiation of ART, or those who initiated it immediately, and then in their negative partners, there was in both cases PrEP for the first 6 months. So in this case, it would extend past 6 months after the infected partner went on therapy to cover for this risk of infection early on. And what did they find? So again, this was the African discordant couples, a large cohort, and basically the reduction from 5.2% all the way down to almost negligible when this strategy was used. So a near elimination of transmission in these partners when they added the 6-month PrEP in addition to treating the infected partner. A fairly significant number, 858 person-year follow-up, and good uptake on both PrEP as well as antiretrovirals, not 100%. In these two seroconverters, both, again, similar to earlier PrEP study I highlighted, had undetectable tenofovir levels at the time. So these arguably could have been a failure just because of inadequately taking the medication rather than the medication itself. So very impressive results, down to 0.2%. And I mean, this, I think, argues, as a number of us have said, that is indeed we should be able to prevent most, if not the majority, of transmission nowadays. We certainly do have the tools, and this is an excellent study highlighting some of that. Now, moving to complications, there was an excellent plenary done by Steve Greenspoon from Harvard, who's an endocrinologist, that I'd encourage you to watch. It's on the web. It's an hour long. And basically, it talked about cardiovascular disease in HIV. I'm still surprised, and I think it's still remarkable that most of my discussions with patients regarding cardiovascular disease center around the drugs. And there, I think it is not yet a good understanding of the contribution of HIV itself. We've seen lots of data from SMART as well as other cohort data that when we control for treatment, that there is an increased risk of cardiovascular disease, looking at taking away traditional risk factors and even on patients without therapy. We've seen data where duration of immune suppression and CD4 nadir predict future cardiovascular disease. Each of these cohorts, going back to 2002, with the most recent being in 2012, all show between 1.4 and as high as 2-fold increase in cardiovascular disease in HIV disease. This most recent one showed, I believe it was 1.4 or 1.45 after controlling for all traditional risk factors, cholesterol, smoking, diabetes, etc. So there really is something that we need to bear in mind when treating patients as our patients get older. This truly is, the data is consistent, a group where we should expect an increased incidence of cardiovascular disease. We've seen this before as well, and unfortunately that our evaluation based on either a recent American Heart Association new guidelines from last year, or the traditional Framingham risk score, or we've seen with the DAD cardiovascular risk score. When we look at predicted rates versus observed rates, all of our models, including what we deem to be our best models, significantly underpredict cardiovascular disease in HIV. So the models are useful, but in each of the three examples I'm quoting, the American Heart Association, and Framingham risk score, and the DAD score, each of them significantly underpredict cardiovascular disease. So we need to bear that in mind. Now, it was enjoyable, I think, for 3 or 4 years to not talk about Abacavir and cardiovascular risk and the ongoing controversy. Last week, Graham was here and he covered this a little bit. It was enjoyable for a while to not talk about it. But this year at CROI, there was a large cohort study, the NA Accord, which some of you may be aware of. This is a 7 cohorts together, including some Canadian participation. And they followed patients from 1995 to 2010, and they presented a poster on their assessment of cardiovascular risk in relation to Abacavir. You'll recall that this all began in about 2008 with the first DAD presentation, which remarkably at that CROI was just a poster rather than an oral. And that first highlighted this 1.7 relative risk for recent Abacavir use. This slide shows all of the cohort studies and some of the randomized control trials that have been done since, and breaks it into those studies with fewer MI events, the MI rates here, and those with greater numbers of events. Now there's problems with all of these studies. The cohort studies have confounding biases. Some of them have small follow-up with small event rates. Some of them are younger patients with fewer event rates. So it's been difficult to sort this out, and I think people they haven't been polarized, but it has been confusing. Some people would certainly take reassurance in the FDA meta-analysis that basically looked at all of the randomized control trials and found no increased risk and felt more comfortable with it, where others would say, well, here's the original DAD and here's the follow-up in 2014 that's replicated it, and we've seen that in some other cohort studies. So it's certainly been a controversy for a long period of time. And this latest iteration with the NA Accord, I don't think really necessarily solves it. So this is the poster that was presented. So they basically looked at two populations, the full study population, and then they looked at a restricted study population. The full study population was defined as those individuals who were either treatment naive, antiretroviral naive, or they were all treatment experienced, but they excluded Abacavir experience. So any individuals coming in who subsequently went into the study enrollment in the study who subsequently went on Abacavir. In the restricted study, they only looked at individuals who began antiretroviral therapy at the beginning of the study, and then either then or afterwards went on Abacavir. So some of the confounding bias with prior treatment before people are switched to Abacavir was thought to be controlled by just looking at antiretroviral naive. So they have a full study population of over 16,500 where there was 301 MIs, and then this smaller restricted study group, antiretroviral naive, when they begin following them, 6,500 with fewer events, and the corresponding patient year follow-up. It got a little more complicated in their analysis. They initially took the same DAD model adjustments, and they applied that to their data set in an effort, obviously, to see if their data replicated the DAD findings. And then they applied a different set of confounders, a very lengthy list, up to 18, and applied that to the full study, and then added more for the restricted study analysis. So two different populations. They did an initial analysis to try to replicate DAD, and then in the smaller study, they controlled for even more things. And these are the results. So in their first analysis, they did find a significant risk for Abacavir, associated with Abacavir, when they controlled for all of the same confounders that were used in DAD, plus BMI in years since antiretroviral initiation. And they came up with a very similar point estimate of 1.68. In the full study population, those who were on treatment and previously treated and initiating Abacavir when they went in the study, this did not achieve statistical significance. They, as I indicated, added more controls for it. It certainly is to the right, but crosses the midline, so not statistically. And then in the restricted study, where, as I said, there was 93 MIs of the 6,500, they again repeated the analysis and again achieved statistical significance. So how to interpret it? The author's conclusion was that this corroborated the DAD study and that it did identify a risk for MI associated with recent Abacavir use. They went further to say, when they looked at these two subcategories in the restricted study, that the magnitude of that effect of Abacavir was similar to age over 60 years or smoking. That sounds reasonable, but when I look at this, we also see smoking disappearing in this as a risk for heart disease as well as diabetes. So I think there's still some confusion around this, and there's still some difficulty in interpreting it. It unfortunately was a poster rather than an oral. And my interpretation of it is it hasn't really clarified this. It's argued that, yes, there's still a signal, there's still a concern here. So it might be interesting once this is actually published and we hear more about it. Okay, so moving on to other complications. This was a very interesting study, again, done by the DAD group. They're looking at the development of chronic kidney disease, defined as a GFR initially 90 or above and decreasing to 60 or less on two repeat tests. So they looked at 23,000 people and found an incidence of only 1%. So that, first of all, that's remarkable that the incidence was quite low in this large cohort. And then they looked at relationship to drugs, and they found 3 where there was an increased risk of development of CKD, and then they looked at cumulative risk over time at 1 year, 2 year, and 3 years. The analysis was done with Abacavir and 1 or 2 other PIs, and they found no relationship. So we've seen this reported before, I think in a similar incidence of 1.12 for tenofovir, perhaps a little lower. This is perhaps a little higher than what we've seen before. And a cumulative 5-year risk of 1.74. We've also seen reports with boosted atazanavir before. Some of that is related to perhaps stone formation. And I think what was surprising is that this rate was quite a bit higher than the cumulative rate of tenofovir. And we see the same thing with Calitra here. So the increased cumulative risk of cardiovascular, CKD with longer exposure related most to boosted atazanavir, followed by lopinavir, and followed by tenofovir. So something we have to bear in mind looking at our patients. I certainly was somewhat surprised about the Calitra effect. I had a patient last week who just had one of his kidneys removed for a transitional cell cancer here at St. Mike's, who I still had on Calitra, and I've subsequently taken off that for this very reason, despite the fact that his renal function was still good. So fairly big numbers, 3.27, 2.1. Now moving to treatments, there were two major studies with TAF, or Stribil 2.0, as some people have referred to it. So first of all, a little background. Tenofovir diphosphate, of course, is the active drug intracellular in target cells, lymphoid, and PBMCs. And what we, of course, give is tenofovir disoproxyl fumarate. And the difficulty with tenofovir, or one of the limitations of it, is that it's not very stable in the plasma. A great deal of it is cleared out, and you do get high plasma levels and not very significant target cell levels. And some of the toxicity, both bone and renal, is of course related to that. So the prodrug that we've used does accumulate more in the plasma, and what Gilead has done is they have developed a separate, distinct prodrug, TAF, which is much more stable in the plasma and has some selective uptake at target cells by cathepsin A, resulting in higher levels of tenofovir in the lymphoid cells and dramatically lower levels in the plasma. This is some of the pharmacokinetics on the data. The top line here is TAF levels in Stribild, and this is in ECF TAF with tenofovir replaced by TAF. So we see a tenfold decrease in plasma levels, yet a fourfold increase in intracellular levels at the target. So the development and the rationale, of course, was to get more drug to target and attempt to limit renal and bone toxicity with lower plasma levels. So quite dramatic. These numbers were taken from the study that I'll present in a minute. So we saw some limited data with earlier phase 2 studies. This is now the large registrational studies for TAF. This was 2 phase 3 studies, international randomized, double-blind, double-dummy active control studies, taking naive patients and randomizing them to either Stribild versus ECF TAF with TAF replacing tenofovir. The endpoints were virologic efficacy and, importantly, some secondary endpoints. The study is planned to go out to 144 weeks, perhaps longer, and this is the first time we've seen 48-week data. So the earlier studies, phase 2, were quite small. This is a very large study with 860 or so in each arm. So registrational and a pivotal study. So the results of the pooled are as follows. Both TAF and Stribild reached 92% efficacy with the viral load endpoint of less than 50 at 48 weeks. Very few failures, as we've come to expect with integrase inhibitors, and in the now traditional FDA analysis, some excluded for no data at the endpoint. The non-inferiority was based on a delta of 12. The difference favored TAF 2%, so statistically they're non-inferior, as intuitively we would guess from that. One other surprising finding was that there was an increase of 211 CD4 at 48 weeks in the TAF arm versus 181. Whether or not that's clinically significant, it's hard to comment, but statistically it was significant. Safety data, no surprises as well, fortunately. So there were 40% adverse drug events in both arms, equally matched. But if you look at grades 3 and 4, it's very low, 1%. Serious adverse events, 0.3 and 0.2, and equally matched between the two arms. And actual discontinuation was only 0.9% and 1.5. So very, very low rates of discontinuation, extremely well tolerated. It's interesting to see that randomization actually works, because 1 death due to alcohol intoxication occurred in each arm based on the randomization. So risky people fall out randomly. Emergent resistance emerging through the study is an important consideration, of course, looking at the different PK here. And fortunately, there was no difference. So looking at each arm, TAF on this side, if we see any resistance whatsoever, 0.8 versus 0.6 in Stribild, there was some 184 in K65R, as would be expected with tenofovir and FTC. And importantly, the integrase resistance was very low, and each of these would be captured with Dolutegravir, at least phenotypically. So low-level resistance of only 0.8%, no findings that were surprising, and certainly nothing that would be worrisome with subsequent treatments. So from the safety point of view, we've demonstrated that it's equal efficacy to Stribild. We've seen that resistance is very similar, and we see that tolerability is also very similar. I didn't show lab data as far as adverse events, but they were very equal as well. So did this actually deliver what was hoped, and that was a decrease in bone and renal toxicity. So this is the 48-week data in this study that is planned for at least 96 and I think longer. And we can see that in Stribilt, we see the 2.8% reduction in the spine, almost 3% reduction in bone density in the hip, but a significant reduction in both arms. So significantly less decreases in spine and hip in the ECF TAF group at week 48. So very reassuring and very nice to see. More importantly, I think, is the renal toxicity and the renal outcomes. So the same story and consistent theme. So with Stribilt, we see with both of them, we see the immediate reduction in creatinine within the first 2 weeks, stable over time. But we see a difference of minus 11.1 in creatinine in GFR reduction versus 6.6. So again, no evidence of significant toxicity. This 6.6 likely represents some of the changes that cobicistat does as it inhibits creatinine secretion. So that may indeed, it doesn't in fact represent any decrease in kidney function, but probably most largely represents cobicistat. Looking at this more thoroughly, the study was a very detailed study looking at these endpoints initially, and as we track in practice, we look at either albumin to creatinine ratio or protein creatinine ratio. And in this case, again at the 48-week mark, we see an increase in both protein to creatinine ratio and albumin creatinine ratio. So these are largely glomerular markers, but also imply some tubular function. In the TAF group, we see a reduction in both of those with this p-value. And looking at retinal binding protein to creatinine ratio and beta-2 microglobulin, both markers of tubular function and tubulopathy, we see a significant increase relative in Stribilt relative to the TAF. So a reduction in the beta-2 and a modest increase with the same p-value. So significantly less proteinuria by all four of these protein markers, and specifically with proximal tubular markers, a significant improvement. So the conclusions: non-inferior efficacy, 48 weeks in a large registrational study. Very low failure rates of less than 1% with little consequence to that failure, with low level of integrase inhibitor resistance. Very well tolerated and comparable between the two groups, perhaps slightly better with TAF. And looking at the detailed renal and bone endpoints, no discontinuations whatsoever for renal adverse events, significantly less GFR decreases and less proteinuria, and markers of tubular protein loss, and significantly less effect on hip and spine. So I think a significant advance in this large study. It's been very good to see. Moving to the second presentation in this with TAF. This is a phase 3 open label study, which is basically a switch study. And more interesting, I think, clinically for us, is this took patients with renal impairment with eGFRs at baseline between 30 and 69. So this is precisely the patient that we're worried about, that we would not previously use tenofovir, or we would have some concern. And of course, this patient group is going to be the same group that's at significant cardiovascular risk, or they'll probably have other factors that put them at cardiovascular risk. So this was a 242 patient study. They were stratified with either moderate or sort of mild or moderate renal dysfunction in the analysis that I'll show you, and then they were switched to TAF. Pre-treatment, they were on various regimes, some of them tenofovir, some of them non-tenofovir including. So we had different reasons for renal failure, of course. The efficacy with the switch, 92% maintained virologic suppression. Not surprising, but good to see. This is to the 48-week mark. and looking importantly at EGFR calculated either by Cockcroft-Gault versus the CK-EPI. We do in all labs in Ontario MDRD. Cockcroft-Gault, of course, is used more by pharmacologists, and that's usually what's listed in the label. So there's subtle differences between these measurements, but they're all valid and they're all useful. The important point, looking at both the mild and moderately renal impaired at baseline, there was no change in EGFR by either of these measurements through 48 weeks. So very reassuring in this more advanced group where we would previously not be comfortable with treating them. Looking at presence of proteinuria or albuminuria at 48 weeks, you can see that there's a significant improvement of either 50% or almost 2/3, depending on which parameter we look at. So remarkable not to just stabilize, but in fact improvement in proteinuria. This is looked at again with markers of tubular function. Again, retinal binding protein to creatinine ratio and beta-2 microglobulin. These, if they would increase, would be indicative of, again, of proximal tubular disease, and a decrease in both, either with either strata of mild or moderately renally impaired. So immediate and significant improvements through to week 48. So quite surprising and quite impressive, I think. Again, impressive is not only a stability in bone density, BMI both at spine and hip, but actually an increase when these patients were changed over to TAF. So 1.9% increase and a 0.9%. Statistically significant from baseline and remarkable in that it was an increase rather than stability. I think this is, there was a question last week that Gord asked when Graham Smith was here, and this is exactly our patient group that we've struggled with. The 56-year-old patient who has some proteinuria, maybe they're diabetic, etc. And we wrestle with whether or not we're going to use Abacavir versus Tenofovir in that group. We don't want to use Abacavir possibly because of adding to cardiovascular risk. And we're nervous about using Tenofovir because of renal. So this really could, in fact, modify that group and make that whole discussion quite a bit simpler. And I think it will indeed do that. The lipid question is a little more complicated. You'll recall that patients coming in were on various treatment regimes, some of them with Tenofovir, some of them without. And you'll recall that Tenofovir does, when we compare it with other backbones and other nucleosides and nucleotides, does yield a more favorable lipid profile. So this indicates that changing from Tenofovir containing regimes to TAF, we do see an increase in total cholesterol, triglycerides, and LDL. Reassuringly, a fairly modest change in total cholesterol to HDL. Whereas if you look at non-Tenofovir containing regimes changing to TAF, there's in fact a decrease. So what TAF is doing here is probably, I'm not so sure we can say that based on this study, it is probably neutral. And these other effects are because you're coming off Tenofovir regime, which yielded a more favorable lipid profile. So in summary, I think that it's remarkable. This group, the mean age was 58 years. So precisely the question you asked last week, Gord, this is the 58-year-old with the proteinuria and high cardiovascular risk. So in order to recruit people with this renal failure, obviously it was skewed to an older age group. The efficacy is maintained. Adverse events are very few. Significant reductions in proteinuria and markers of disrupted tubular function, very reassuring. No renal tubulopathy was developed. An improvement, remarkably, in bone density. And the lipid, a little more complicated, but perhaps not yielding a significant clinical benefit, but dependent on what regime they're on prior to the switch. So again, I think this is will be relevant for this patient group where we do have a real struggle right now. So moving to other treatment, this is one quick slide on maturation inhibitor. We heard about these a few years ago. This is a BMS product. Berivamat is what you may recall initially being studied, and this is being termed a second generation. The problem with Berivamat was that for individuals with GAG polymorphisms, of which there was almost 1/3 in naive patients, the drug failed because of some intrinsic or a priori resistance. And basically, they now have some data looking at various doses. This is a phase 2A. They're just trying to sort out doses still. Significant reduction isn't a monotherapy. So the only thing I wanted to point out here is it's early, but we may see this again. Significant reductions, and they're proceeding on to a phase 3. Some of the controversy regarding Abacavir and tenofovir and our debates around that has been the relative efficacy of each of those backbones in individuals with a high baseline viral load. So several studies, the most notable and the most important was study 5202, showed us that in individuals with baseline viral loads over 100,000, that tenofovir indeed was superior to Abacavir containing regimes Kyvexa in suppression. So that's always been a concern. For GSK, they are, as you're aware, developing Dolutegravir and have a single tablet regimen, Triumec, incorporating Kyvexa. So the question has been whether or not there would be some diminution of potency, virologic potency with that regime in higher viral loads. So this isn't a meta-analysis, but it looks at each of their registrational studies. Single was the study presented by Dr. Walmsley initially, where the comparison was Atripla versus Dolutegravir in conjunction with, paired with Kyvexa, Abacavir 3TC. Spring 2, which I participated in, was a comparison between Dolutegravir and Raltegravir and investigator-chosen backbones, either Truvada or Kyvexa. And indeed, myself, as like most of the other investigators, chose 2/3 Truvada over 1/3 Kyvexa. And Flamingo was an open-label study, unlike the double-blind randomized studies, an open-label study of Dolutegravir versus Darunavir. You'll recall that Single demonstrated superiority to Atripla, and it was the first study that's ever demonstrated superiority to Atripla at a primary analysis. You'll recall that Flamingo, this was largely being driven, however, by tolerance, although the virologic efficacy was similar between the two of them. It was superior, but mainly by tolerance. Flamingo demonstrated Dolutegravir was superior to Darunavir, particularly at higher viral loads, and Spring showed non-inferiority between the two studies. So in the top panel, we basically see that Dolutegravir performs across all viral loads versus the comparator, probably not statistically significant, but a trend to superiority at higher viral loads. And the point of this analysis was looking at the two backbones of either Kyvexa versus Truvada to see if there was indeed a difference, and particularly at higher viral loads. And indeed there isn't. So this previous concern about Abacavir and what it's being paired with does not seem to come into play with Dolutegravir. The next study I'd like to present quickly is the Latte, also, which I was fortunate to participate in. Latte is using Cabotegravir, which is an analog of Dolutegravir. And the reason this drug is being developed, it has a long half-life and has pharmacokinetics such that it can be used as an injectable. And indeed, as an injectable, can be given and deliver therapeutic levels for up to 3 months after an injection. And the plan is to pair it with Relpivirine, which will also be delivered via an injection, a depot injection, perhaps once a month. So this is initially a first study looking at these two compounds together in an oral format, looking at efficacy to see if it can then progress to the injectable. So this is Latte 2, which is ongoing now, and Maple Leaf is participating in, looks at the injections. So a somewhat complicated study in that it looks at Abacavir in 3 different doses. It's a 2B study, still sorting out the dose, paired with different nucleoside backbones. If patients are fully suppressed at week 16, at week 24, they're then rolled over from this induction phase to a true drug maintenance phase, which involves the Abacavir continued at that dose, paired with oral rilpivirine. And all 3 of those are then compared with Sestiva and 2 nucleoside backbones. So we've seen earlier analysis of this at week 48, and basically at CROI this year, they looked at 96 week. And so 48 week, this was previously presented. If we look at the 3 Abacavir arms, the top 3, all of them perform somewhat better than a tripla. So 2 things have been demonstrated. This induction maintenance, where patients are rolled over to 2 drugs, continues to yield good efficacy, and in comparison to one of our standards of care is as good. So this will continue based on these 3 different doses. What's being advanced is a 30 milligrams, and that's what's going to be used in the injectable format. So basically, this is the results at 96 weeks. So somewhat superior, although not statistically efficacy. Good CD4 gains comparable. You can see that virologic failure is very low with the Abacavir. Very low discontinuations compared with Sestiva. And a small study, there may be some signals here, but no dramatic safety signals coming out. And as I say, the 30 milligrams has been selected now for further clinical development. So Latte 2 will be the study to watch for as far as the injections. And the application there, I believe, will either be in less resource-rich settings, perhaps with periodic injections, or in PrEP use. And you can imagine if you had an injectable every 3 months or so, that could work well in that scenario. This is somewhat complicated, and I'll try to, we need someone like Mario Ostrowski to explain this, I think. But 3 or 4 years ago, we didn't talk about cure with HIV, and now we've talked about it in the last 2 years. Initially, I think, with HDAC inhibitors and some promising ideas. Basically, as you're aware, our chief limitation to cure is this latently infected pool of HIV cells that are quiescent, that don't divide, and for which all our drugs that we use now have no impact on. And the strategies have been looking at trying to activate that latently infected pool, and once they're activated and dividing, to try to clear them off and kill them out. So the so-called kick and kill strategy. So this is a Gilead Science product. They not only do TAF and some Hep C stuff, they're doing cure, which is kind of impressive, I thought. So this is a product that they've had, and in fact, from what I understand, maybe was developed for something else initially, and they even have some toxicology data on it. And this basically looks at PBMCs from HIV-positive donors ex vivo, and they're given 2 doses of this product over time. And this panel basically just shows that it's activating these T cells and releasing this latent virus. So that's promising. And then some data here, which is a little too complicated to explain, but basically there's some evidence that this, in fact, is perhaps decreasing the HIV reservoir, although that's quite preliminary. So what is this product? It's a toll-like receptor 7, and basically that's something that is part of our innate immune system and linked to adaptive immunity. An activation of a toll-like receptor, which is on dendritic cells and helps present antigen for our immune system. Activation of TLR7 increases antigen presentation, which could be a good thing, of course. It enhances natural killer cells and CD8 T cell activation, and activation of CD8 positive T cells, which have been linked, of course, to better HIV control. So the study that they've used in a macaque model looked at infecting these macaques with intrarectal challenge, treating them with tenofovir, and remarkably someone else has integrase inhibitor, which is a very good drug, obviously, administered over a period of time, suppressing them virologically, and then administering the TLR7 to see if they can activate latently infected cells. And what did they find? Just quickly, the red are placebo animals, and the blue represents TLR agonist. So these are 9 macaques. So at this time point, the macaques are infected. They go on antiretroviral therapy. All of them are fully suppressed for a period of time. Then they're administered multiple injections of this TLR7, and what they're measuring here in the blue, the TLR agonist rather than placebo, an increase in viremia, indicating they're releasing some of this from the reservoir, and more notably, a decrease in the set point post withdrawal of antiretrovirals. So it looks like both things may be happening. Now, this is a macaque model. It's small numbers, but interesting and promising. Another surprising thing that the SIV DNA levels were reduced by this amount in PBM and colon and lymphoid tissue. So not only do they have plasma on this, but also tissue samples. So very early, but interesting, and I think stay tuned. I have 4 quick slides on Hep C. Hep C is sort of a whole a separate, complete talk. I think 2 notable studies, Ledipasvir and Sofosbuvir, or Harvoni, was presented in this study, and basically 12-week of therapy in genotype 1 and genotype 4. Almost all of these were genotype 1 patients, phase 3 open label. The wonderful thing about Hep C studies is you don't need placebo control, you don't need a comparator arm, you just treat them and get SVR12s and say, okay, it works or it doesn't. And you get these spectacular numbers. But basically this study, relevant for our audience, is not first use, but use in large numbers in co-infection, and looking at not only overall response, but those previously treated with Hep C, some of who were previously treated with Sofosbuvir, and those with cirrhosis. So the contemporary recommendation, at least in the States, is that our Hep C co-infected patients should be treated in the same manner as our Hep C monotherapy patients. They respond as well. There does not seem to be the toxicity we would expect. And the one issue and the one problem is drug interactions, I think. But spectacular, as we've seen, in fact, revolutionary numbers over the last few years, but also surprising in co-infection and in cirrhosis patient and previously treated patients. I'll skip that, I think. It's a long discussion. The second Hep C study was the Cladosphere combined with Sofosbuvir. This is a BMS drug, and this is the Gilead drug. The previous one, of course, was Harvoni, the Gilead drug. Why this is important is the Ledipasvir is primarily for genotype 1, which is our dominant North American and European genotype, whereas the Cladosphere is thought to be pan-genotypic, and in other areas of the world where there's a large proportion of patients with other genotypes, pairing this with Sofosbuvir will be useful for the other genotypes. So basically 2 arms to look at here, Sofosbuvir with the Cladosphere in different doses depending on what it's paired with. If it's with ritonavir, you down dose. The usual dose is 60. If it's with NNRTIs, you up it from 60 to 90. And they were either treated for 12 weeks, and in the naive patients, they try to cheat and get away with 8 weeks as opposed to 12. And what happened? Everyone who gets 12 weeks does spectacularly well, 98, 96%. The 8-week therapy, there is a hit, so that probably won't persist. But overall, very similar spectacular results. So 2 regimes, co-infection, all oral, no ribavirin, and short duration. So just quickly, if Gord will indulge me, I wanted to do my predictions for the HIV landscape for the next, probably should say 2015, 2016. So first of all, Triumec, Dolutegravir, Kyvexa it should say 2015, of course. It's still not on the formulary in Ontario. It has been in Quebec and BC for a long period of time. I would predict that it will be added and will be certainly a favorite first line. I think TAF they'll apply for registration, of course, and I think it will solve some of these difficult patients we have, older, cardiovascular risk, and renal. And now that we've seen the data on those mild to moderate toxicity, I think it's will prove to be very useful. So I look forward to seeing that. I don't know if there's any advocates here, and I don't know if AIDS Action Now still exists, but I kind of miss AIDS Action Now. I don't know about you, Gord, but it was nice when they were around. AIDS Action Now is going to reawaken and advocate for PrEP, national and regional guidelines. Why don't we have guidelines nationally for this? There's going to be an inclusion of label of tenofovir with regulatory agencies. There's one country in the world where tenofovir is included in the label for PrEP. That's in America, nowhere else. And of course, the biggest barrier for PrEP is that we don't have coverage or a means of supporting this. The HIV Hep C story, or the Hep C story, will continue to improve. These treatments are shorter, less toxic, extremely well tolerated, and there'll be an improvement of this treatment cascade, which, now we're treating 10 to 20% of Hep C patients. Hopefully we'll see that improve, and primary care providers will come in there. Now, the least likely prediction, I think, is that our interest rates are going to stay low forever, but only slightly less likely is that we're going to see Dolutegravir co-formulated with TAF, and it's going to be called Perfectovir.